Bem, muito boa tarde, bem-vindos a este encontro. O Sr. Professor Carlos Pereira Alves pediu-me que estivesse aqui com ele nesta mesa. É uma coisa que me vai acontecendo cada vez mais, é que não me pedem para falar, mas pedem para comentar. Também me pedem para falar de coisas de ética. E normalmente isto não abona nada de bom quando a gente chega a esta fase na vida, por uma razão qualquer. Mas este assunto é verdadeiramente um tema atual e é um tema do qual eu tenho alguma visão, que é necessariamente minha, mas que é refletida, e portanto as palavras que vos vou dizer, 5 minutos, não mais do que isso, tendem um bocadinho a centrar o tema para o que vem a seguir. Esta sessão aqui no Grémio é sobre Value-Based Healthcare, o futuro da medicina intervencional e dos resultados dos outcomes dos doentes. E verdadeiramente, além das intervenções destes dois dinossauros, haverá Keynote Speakers, o Dr. Fried van Eenennaam, Chairman de Value-Based Healthcare na Europa, vem da Holanda, muito bem pronunciado, mas Groningen é muito pior dizer. Depois uma perspectiva nacional pelo João Marques Gomes, que trabalha connosco no Nova, e depois Let's Make It Happen pelo Diogo Reis, da Prologica, e depois haverá um jantar ao qual eu não poderei estar, mas que pelo menos o jantar vai ser bom e o debate acredito que também será melhor ainda. Mas o Value-Based Healthcare é como aquelas designações da sociedade, como a sustentabilidade, como a liderança e tantas outras que têm, de que nós falamos muito e ou não conhecemos tanto ou temos dificuldade em praticar. Quer falar em inglês?
Estava previsto, fosse tudo em inglês.
I was saying, sorry, I was just briefing people. I really apologize. Value-based healthcare is one of those designations in society, like leadership, sustainability and others, for which we are always talking about that, but either we don't know the meaning or we don't practice. Now, the meaning, I think everybody will know here. This was introduced by Michael Porter some 11 years ago, and Barbara Theiserberg, and it is a business concept, and it is a concept that was initiated in a country where healthcare is mostly a business, so there is no social dimension or very little social dimension. So the value is simple. We have been practicing medicine being paid by acts. How many? The Prime Minister will easily say, we have done more 400,000 surgeries and outpatient clinics, so the healthcare is better. Well, that is absolutely redundant, because I'm not sure about the quality of those procedures. I don't know nothing about being needed or not, and I know even less regarding how much they cost. For me, as a citizen paying taxes, I really do not care whether any one of the gentlemen or ladies in the room gets 6 stents or in the coronary arteries or gets some bypass grafts. Well, I would rather prefer you get some grafts, of course. But what I really care is how many of you after this surgery will be looking after grandkids or playing golf or driving your car without complications and the need to redo those procedures. So basically what we want is a dimension that links health with value we create for people. So this is an equation, as you know, in which you have outcomes, which are results in healthcare, and the costs we need to achieve those. And it's not per patient or per going to the doctor, it's per complete cycle of treatment. It's for a completely treated patient. So this is the concept. So there is nothing wrong with the concept. For countries like Europe, the concept does not, countries in Europe, the concept does not apply completely, because we have another dimension that we can list in the outcome nominator, which is access. And access is a social dimension for countries with public healthcare systems or mixed healthcare systems, as you have invariably due to European social tradition in Europe. Now, we can talk more about that later. Now, having said that the concept is really easy and it's a brilliant concept, its application is not straight. Why? For three sets of reasons. First, it is new, and of course something new is a totally different mindset, because I've been paid per operation and not per patient treated. And it's like you take your car to the garage, and if each time you go there to repairing the radiator, you pay one go. And you say, no, I don't want to pay for this. I want to pay for a completely repaired, good quality car. Now, having said this, so there is the resistance for being new. There are two other problems. One is whenever any one of us talk about outcomes, Ronaldo Delgado knows this very well, we have to relate those outcomes to the complexity of what we're doing. So you cannot talk about outcomes blindly. You need to relate those outcomes to the complexity. Because I might be very good in the low risk and be very bad in the high risk, or even vice versa, which is more strange. So, apart from cardiac surgery and a few other specialties, complexity stratification or risk stratification is a difficult issue. You may have case mix, but this is for a group of patients, for a group of diseases, not for disease per se. The other thing is it is painful to implement value-based healthcare. Well, you agree? Well, if you...
I agree with the last thing, yeah.
Yeah, sure. No, it is complex. Well, Michael Porter itself launched iChom. And I don't want to be abusive, but probably I don't think he is so found at iChom now as he was before. Because that's a very big organization. And it takes complexity, computing, and people to work on that. Well, I know that because in the public hospital where I work in Santa Marta, we have around 8,000, 7,000 something cardiac patients from open heart surgery followed for 1 year. And it takes me 2 nurses, one in the shift, like phone operators calling the patients at home. Once I operate a very well-known guy in Lisbon, very well known to you, or you, I repaired its mitral valve, and he rang me asking, Professor, am I okay? Are you expecting me to die? I said, well, I suppose you're okay, but is there any problem? No, I have a nurse ringing me every week, asking if I can have sex, if I feel pain, if I'm moving around. So now it takes time, it takes people. And most of the institutions, although they want this, they're not ready to pay for it. Because they have not seen the utility of it. I gave an example before this address that I'm just finishing, that whenever, when the cars appear, we have carriages dragged by horses. And those were good, 2 seats, 3 seats, 4 seats, pair of horses, 1 horse. And then Pioneer in France came with the same carriage with a steam engine. And that thing weighed some 4 tons or 5 tons. But you could not steer it, you could not move it around. Cars would never happen if that effort would continue. Until Mr. Ford got 4T, 2 seats car, production line, 2 seats, very cheap, and then you get a disruptive innovation. Well, iChom is not a disruptive innovation. iChom is a lot of complexity. So we have to change it. At Nova, and I'm concluding, we have a collaboration lab, and you have a lot of research efforts which are working hardly in the lab with PhD people, very bright people, in order to create a simpler tool, like a scorecard, to make this analysis more swift and being able to change the market. So I'm really eager to hear what our colleague and all the other João Gomes, I almost know what he's going to say, but Diogo have to say about this, and I'll pass on to my co-chair. Thank you very much.
Thank you, Fragata. Well, let me start on behalf of our organization, APDH, and myself, to thank the speakers, to thank the discussants, to thank the audience, to thank the sponsors and partners, our sponsors and partners, Nova University, new university, and the pharmaceutical industry to achieve this meeting. Two things, very briefly, two comments made on mainly by a doctor, by a surgeon, about this, about the topic of this, let's say, the value-based healthcare. Of course, that for us doctors, and I think for everybody, what our target, our objective, is to achieve the best outcomes at lowest cost. Obvious, my dear Watson. We all want this, and that's the meaning of this. Value is a balance between benefits, results, outcomes, and costs. So the problem, to me, as a doctor, is how to measure. As a doctor, I could say, probably it's easy to measure the costs. I don't know if it is. Economists will say, or financial people will say. For me as a doctor, probably it's easy to have an analysis of costs. But when you go to results, to medical results, to outcomes, it's more difficult. More difficult for two reasons. One, we all know, and especially doctors know, that medicine is an activity based on uncertainty. We all know that. And that's one of the reasons why we start talking about medicine evidence-based. But when I look to that, I saw myself saying, but me as a doctor, I've always done the things based on evidence. So, but the problem was that in the beginning, the evidence was just clinical. So it was individual. So it was based on my results, just me and the patient. Nowadays, the evidence-based are based on collective data. It's based on results of trials, results of consensus, but even according to that, we have three situations. We have situations the evidence is so strong that we can make recommendations, strong recommendations, what we call recommendations 1A. But after we have other evidence that are weak, and that doesn't allow to make a recommendation, they're just allowed to make suggestions. And we have a lot of situations in medicine that we have no evidence at all. It's what we call a black hole. And we have to use the clinical judgment and to decide what you think that probably will be good for this patient. To complicate more this, nowadays when we start talk about outcomes, we don't mean just health. We mean a lot of that. We mean wellness. And so it's a mixture of health and wellness, and it's even more complicated. My second comment is about another thing that we are facing, we as doctors, in our real life, in our activity. More and more, we are dealing with the computer and with checklists, screenings, scores, profiles, specialization, hyper-specialization, digital world, and of course, and even now, for instance, in these last years, the American College of Surgeons are starting a new program that they call strong surgery. When they have a new program in the computer, in order that when I'm going to operate someone in an elective surgery, I should prepare this patient as the better. That's why he should go to the operating room as fit as possible. So that's why the reason we have one thing here, the go fit. So go fit to your surgeon. And we have to check nutrition, check and correct if possible. Sugar, anemia, previous medications, smoking cessation, previous morbidities, physical and emotional status of the patient. Of course, that we do all that in our medical file, but it's true that sometimes you can forget some of these things. So we will not forget if they are in the computer, and we just going to cross. But there is a danger in that, like there is a danger in a bad specialization or a danger in the bad use of the computers. Is that very easily we as doctors, we can forget our main job, that is clinical and judgment, clinical judgment, and that's from the beginning is the clinic, and after came all the technologies and the relation between the patient and the doctor. So very easily the young doctors could just start being, let's say, even if I'm still young, of course, and I will always be young, always a child. But I'm very, very interested in what I can catch from the digital, from the computer. And I think there are a lot of positive things that are helping in using computers. But there is a difference between being a doctor that use and welcome the digital, the computers and digital world, is different than transforming myself in a digital doctor. I'm not interested in being a digital doctor, but I'm interested in using as much as possible. So let's finish with this. This is just some points made by a doctor, by a surgeon. And so like that I should finish with a thing. You know, the well-known philosopher and mathematician, Bertrand Russell, wrote a small book about happiness. And he started this book with a thing that I never forget. The animals, if they are healthy and have food, they are happy. Humans are more complex. But it's our job to contribute that you, me, everybody, we should be more and more healthy and wellness. Let's say, more happy. So be happy. Thank you very much. And now, we are waiting if it is working, if not working, I don't know. Não sei se é Paula. Não é Paula, não. But you know, high technology problems sometimes. So, okay. Well, so the floor is yours, my dear Fred, and I hope you'll try to do your best without helping, be a surgeon. Sometimes you have to solve the problems in the moment.
You can judge it in the end. That's right.
Okay.
Thank you. Thank you very much. Okay, good afternoon, good evening. Pleasure and honor for me to be here. The good news is you're going to get all the slides, so you're going to get a stick, so you'll have the slides and you'll have some more information. Now I need to look sometimes at my notes a little bit more, so I'll try to tell you what's up there and what I explained, but I'll dance on that. But the story is quite clear. So, so why am I? If it goes up, we'll see, right? And you see if I'm sort of online. So, I'll just start. If it's there, it's there. Okay. We'll just have some fun. Thank you. So let me start with why I like to be here. The main reason for me to be here is because, at least at Philips Healthcare Center Europe, we get more and more people reaching out from Portugal and from Brazil. And since my Portuguese is 0, it only sounds very nice, I thought it would be very good to be here. So my colleague, who can always say to me, you know, there are 5 or 6 sessions from the Philips Healthcare Center. You go there and see if we can contribute, if people like it or if they don't like it. But the good news is that people are reaching out. So some people are in the room who are doing the online blended course and will do the exam. Other people have asked us about the Philips Healthcare Prize or about examples. So that's the reason for me to be here and see if it works. That's one. The other thing, I'm very curious by nature, but I'm very curious about what are you thinking, what are you doing, what's your experience. We're fellow Europeans, and there's a lot that's sort of common for us, but also there may be some lessons that we can share, and there may be a lot of things that you can contribute as well. So, thank you for at least so I have the slides now, so I don't work for you, but it works for me. So that's why I'm here. Now the good news is, I think the good people here already sent you a package of information. So you have that already sent, so there's a lot of those materials in it already, so that's good. So see if it's useful for you, and if you want to have, I said at the front, if you have any questions or any thoughts, just feel free to reach out. For me personally, is LinkedIn the easiest, but please feel free to download or other things. It's all there. There's around 1,000 cases available, and that's the main thing, to see if we can get. Of course, they do not exactly fit your situation, but the thinking or the development make what you think. So that's number one in terms of the good news. Now, I was basically asked to do two things. Number one is show a little bit on things are happening in Europe at different spots. I'll have an example of my country with Danny Peter. I'm going to have an example of Denmark, and you're going to talk about Denmark as well, on osteoporosis, and I like to spend some time on what was the original case, the Martini Clinic in Germany, and see how they're doing, but there are many more. So on dinner or anything else, we can discuss other cases. What is my experience on this? One is, I'm personally very much interested in how do you get things done. So I'm interested in the implementation bit. Sometimes people call it the dirty or the muddy work of getting it going on Monday morning, and we don't get the data, and the health administrator or the database people are certainly, from their perspective, not interested or not possible. How do you get this going? So my natural tendency in healthcare has been, if you want to implement anything, you need to implement on the team. It's a team effort, and that team is growing. Where it may be a surgeon with an assistant, it has been growing. And how do you get these teams working? Well, a lot of the organization is not helping, because they pay differently, they're structured differently, they're specialized differently, and as a patient or a family member, I basically don't care. I just hate it to be ping-ponged, and I don't have a clue if it's going to be helpful for me. I just hope. So that's probably why I like to work with Porter. I know for 20 years, and he knows I'm just crazy about great idea, great concept, love it. How to get this working? So I'm very happy to say that I did that. So with the Decision Group, that's my firm, we did a lot in healthcare before for 25 years, basically on how do we get things done. And so we started with value-based healthcare. Now we have around 130 individually where we were allowed to help people implement. And that started with cardiology in the Netherlands, how we get it going, and that got sort of a methodology in filling out outcomes. There was no outcome, NHS was unclear, Cleveland Clinic data, things were a little bit unclear, so we needed to do all that work, and we basically came up with a method as well as something else. So that's the first thing that we did. In oncology, a lot of work, in internal medicine, in elderly care, in palliative care, and now in primary care. So it has been a journey for us, sometimes, whoa, how do we get this going? But just try to get it going. And we learned a couple of things that we can share. Yep, so that was one thing. And then Michael Porter said to me, Fred, you're in Europe, yeah? So why don't you spread the word in Europe? I said, the Netherlands is too small from the US perspective. I understand that. I said, wait a minute. There is something different. The US is great. I love it. I like the US very much. I really do. I see some of the most amazing, wonderful, great things, and I see the worst. So actually the variation is much more extreme than what we are used to. So I try to look at the ones. So he asked me to do that. I didn't really know if it would work, but we started doing that. I'm very happy that the members are growing. We get 200 to 300 questions a week on value-based healthcare. 80% say, oh, okay, talk to that one, or maybe this case, or that may be helpful. And 20% of those questions, some of those questions are, huh? Some questions, great question, no clue. So how can we in the network and in the community do that? It's focused on Europe. We're very happy with the growth. We're very happy with the fact that people want to do a green belt exam. We're very happy that people download lots of stuff. And the big event for us every year is the Value-Based Healthcare Prize, because it's fun, but it's also because it inspires and all these people in these complex hospitals and these complex situations. There's only one prize in the world, and that's why I'm happy the board is the only chair, that really tries to value those people and teams that generate value for patients. There are many prizes on innovation, or renewal, or the best paper, and I love those, and I think they're important. But I said, well, why a prize? He said, it's probably a good idea. Because we do not have something that says, wait a minute, you did a wonderful job in osteoporosis, or wait a minute, you did something wonderful like this. Yep, so, and it helped us bring in those cases, and I hope they're going to inspire you and bring that forward, and we work with the people there. So that's my invite to, let's say, the community. And it's an individual membership. That's what it is. And if you like it, you like it, and that's it. Okay, then the Decision Institute, sort of the sister of the Decision Group. I am also mad about education, working at universities, both business schools and economics departments, and on healthcare. So I like education a lot. That's why we started with this blended thing online. So we do a lot of that. And in Portugal, I was quite happy that one of your health insurers, private health insurers, asked us a couple of weeks ago, I think, to do an internal training for them on what does it mean in terms of value-based healthcare, and what would it mean for a payer from a health insurer in a system that is slightly different than where I come from, or what I see in the UK, or what I understand from Germany. So there was actually another signal, say, wait a minute, something's happening here. So let's see. So I hope that's the case. Now, let me check if I sort of covered that you'll recognize it at home. So the slide I have prepared, can you see it? But the slide I have prepared sort of shows the value-based healthcare examples in the world and also in the Netherlands based upon last year's applications. Right? So it shows, of course, from Germany, from Belgium, from the Netherlands, from Denmark, from Sweden, from Italy, from India, from Kenya, from New Zealand, from Australia. That's not Europe. But it shows that a couple of things are happening in Europe, and these are applications. These are only the applications that after the 3 applications I suggested to apply. So you may have a chance, either to win a prize or to be in an endorsement. Say, wait a minute, this is a great early example. We want you to help. We want to help you. We want to show to your bosses that we think it's a great idea and that you need help. So you have the slide at least, because that was the first thing that people asked me to do. Now, before I talk about value-based healthcare, I sort of like to give an introduction in my best handwriting. And my wife always tells me, you could have been a doctor given your handwriting. So that's probably the only thing. I'm just a simple economist. So I try to help. So just as a working definition, nothing new. But it's good to say, value-based healthcare delivery is a concept and a framework plus a growing set of methods and methodologies. It's not just outcomes. It's growing. It's a sort of on its way, based upon this notion. So I really liked your notion of saying we try to make it simpler or workable, not on a fast scale, but on a smaller scale, or make it work a little bit easier, given what we can do. So that's what it is. It's aimed, and that's I think is important, at least every time. It has a very specific definition of patient value. That doesn't mean that you cannot create other value, it's fine with me, but this notion is very specific. It's a specific patient group or stratification, defined very well, and it shows the outcomes. And I would say 5 to 7 maximum, please, because we go bananas if we need to measure more, and make a smart set of medical measures and a smart set of quality of life measures that varies a little bit per medical condition, but start with the most important. Don't fall in the trap of perfection. Don't fall in the trap of everything. It doesn't make any sense. You don't have the time to do that. So it's a little bit of I'm an implementing guy, right? It's a little bit of an art in getting those that are useful for the patient and the family. They can sort of understand, or their GP can help them understand. But it's only to say, probably you need to go to these doctors. And they need to look at your specific case. Because of course it's going to be different. There's variation in humans. So we cannot capture this as an average. There's no way. But we can also use the averages. So that's number one. And number two is use that in that way and try to start thinking about how can we as a team, and I don't mean a department, as a team, think about improving these outcomes. And the impressive thing is that most of the time when you have patient discussions and you talk with nurses and you talk with doctors, and you say, you know, let's forget a little bit, what's your idea anyway? What do you think is good? And then let's think about the outcomes and what do patients really think is important. And then, most of the, not always, most of the time, you're on a way to actually reduce the cost over a cycle of care. Not always, but most of the time you are. And we know why that is, right? Because we know the cheapest patient is a patient that has no problem. So the more you're able to do that, and you do that over a cycle of care, it works. That's the trick. And if you have those teams that are very good at that, do this, and other teams focus on other things, not do everything and everybody does sort of the same protocol thing, that's not smart. What's smart is that you know which patient certifications you're absolutely darn good at and where you can move the needle. So we want to move from volume drivers to value, so you show and you learn and you have fun in doing that. And then you move, since you're very good at this, you move to volume, and other people will do the more complex or the easier or something like that. And now you're probably going to tell me it's going to work when I'm finished. No? Oh, it's fine with me. So, but the thing is, so it's a very specific definition of patient value, and you need to be a little bit smart and practical about this, and you can move over time with the outcome measures. So I hope to talk with you on cardiology, how that worked in the Netherlands. This at first we looked at our first outcome data and the quality of the data, and we said it was 70% reliable on those things. We would be embarrassed to show it today. But we accepted it then because we didn't have anything better. And it helped us think about improving and showing it to payers and get them involved and changing the mindset from a pure cost-cutting volume idea to a value idea. And we know it's not easy, but we need to together take these steps. And we could talk about Denmark. Every nation has its different ways of doing that. In my country, it's doctors, and then I need to bring in all the others who sort of try to avoid them from doing the right thing, and then we somehow get there. And in other countries it's different. Okay? But that's a specific patient value. And why? To align patients and doctors, health managers who run the budgets, payers and other people, to look at the same measure of success. The big issue, according to Porter, originally is we do not have a common. You can do whatever you like. I'm just going to see if I can get it across. So, and once I have slides, I have slides. Yep. I try to stick with it. If you want me to stop me, please do, because I'm trying to bring a vision that you cannot see. Okay. And this is the thing. So the fundamental issue in healthcare is all groups have different ideas of what success is. And you don't need to be an economist to understand, or a business person, if you don't have a common measure of success, everything's good and everything's going to be bad. If you use a different quality measure than I do, and if I change the game by redefining costs, everything's good, everything's bad, and it becomes a political power game. That's what it becomes. Because we are not aligned, and this is what we think is a good thing to do. And we don't have a similar definition. And whether in the US or whether in Europe, it's everywhere. It's different measures. And if it's a different, and not because people want to do it badly, it's because we haven't voted. That's the reason why. So we need a measure. And then the key thing is to have just a little of those and let the teams and the doctors and let them figure out how to do it. We don't want governments and others to have endless streams of process measures. Yeah, you're going to do something whatever you want. we don't want a new explosion of measures. We don't want, if I buy a car, your example, I'm not interested per se in the performance of a little part of it. But I know for the mechanic it's very important because they need to measure that thing. But we make a mistake in healthcare that those small medical measures are in big systems, and then who does what with them? Don't collect any data. I'm not talking about the scientific part. I'm talking about delivering care. Don't collect data on which you cannot act. Don't provide data to people that cannot act upon it. Only try to do something. But the only one who create value in healthcare are the doctor and their teams and the patient and the family. That's the connection. they need to be doing that work and then show in an easy way. And we know it's not perfect and there may be nuances and all that, but we need to understand that you're generally doing a good job, and we understand that if it's not a good job, we're not going to penalize you. We're gonna applaud that you report it, that you don't cheat with numbers, that you don't hire me to say, Fred, can you fiddle it in such an epidemiologic, econometric way that we're still within the 95% reliability, and if it's not statistically significant, then it's no problem. Really? You want to have that discussion? Are you crazy? What do you think that would help your mother, your child, yourself? If you would continue with this idiotic idea? I love econometrics, don't get me wrong. And I think it's important, but it doesn't work if you have small numbers in interpretation. And so you need to not go into this. I'm still a good doctor because, my patients are worse than yours. Really? Every time we do that, it turns out they're not. And I'm not saying you're doing the wrong job. I'm not interested in if you're doing the wrong job. I'm interested in, do you fairly show it? And do you lose sleep over it? And are you going to fix it? And are you going to improve it? And that's what we need. We don't need behavior where people start cheating. That's the reason why it's here. You with me? So I always try to say, this is language. We try to get to a common language that people can reasonably understand without going into the nuances and the difficulties of the medical or the social domain. We just want to get that out, and we trust the teams in delivery. We don't want to second guess people. At least that's the idea. Okay? And I think that is different in the US, but not in principle. Because I know my health economics friends, I'm an economist, I'm not a health economist, and they all talk to each other and they do the same thing. Right? And they come up with the same ideas, and some of them are good, and most of them are bad. And some are really good friends of mine, but they know I think about that field in this way. Okay? So let me now give you some examples, and many, yeah. well, I'll see if this works. Okay. So I'm going to repeat this, no I'm not. So this is all I try to tell you. So let me talk about, I'm going to try 3 examples, because I was asked to show in 3 different, or in some countries in Europe, what is happening, and I try to sort of have different stories, okay? So that they're sort of on different angles, but there are many more. Fortunately, I don't need to prove it works. I don't know. I don't need to say why it's a good idea. I don't need to say what it is. I don't even need to say that it can work. How to do it in your situation, that's difficult. But that's fine. Don't need to do it tomorrow. Okay, go. First one is my hometown, home country, the Netherlands. This is diabetes. Anybody heard of it? This is about diabetes 1. You did? Good. Anybody else? You did? Yeah. You should in your field. Yeah. Okay. Correct. Okay. Let me do it a little bit more systematic. So it's diabetes 1. These are the people that won the prize. And let me give you some data, and then I'm going to give you the story. So diabetes 1. It's wonderful. Diabetes 1 in children. Serious problem. So what was the thinking of the guys who were there, saying, wait a minute, we are in pediatrics, we are seeing all these kids with diabetes 1, and what is difficult in it, and this is an epidemic. How are we going to deal with this? Because we have serious problems in dealing with this. So what's the medical strategic problem with diabetes 1 in children? Number 1 is, you don't know it. Right? So it's hard to figure out if the children have that issue. Suppose they have the issue. What's the problem then? You need to train these kids and their parents, most of the time I'm afraid their mother, to deal with this diabetes 1. In terms of eating, in terms of dealing with it, in terms of going to school, in terms of doing all that. And that's important. So they go home and then you hope they do it. And then you look at your immediate care facilities, And of course, when these children are becoming a little older, they certainly don't want to comply with all this. So you're flooding your departments, and then they go to the pediatrics. So the hidden cost of this, the human cost and the cost in the system, is incredible. So this is a serious, big thing that we do not have any idea how to deal with this. And they figured it out. So they said, well, wait a minute. First of all, these are the medical issues, right? We need to understand what it is. We need to get the people in that do this. We need to train the people how to deal with this. And then we need to almost 24/7 have a system in which we can observe that it's going. And then we need some interventions at some point. And we know that, of course, some of these stratified patients, specifically when they're older than 12, 13, 14, 15, 16, they don't want to deal with this diabetes 1 anymore. So of course you're going to have all these problems. And we need to deal with that on the one hand. On the other hand, we want to make sure that these children and their parents have a life. That their life is not dominated by, oh, I'm in school, oh, and I'm still doing this, I'm doing that, oh. And everybody's going to go bananas, and everybody's schools go bananas. And the children will have a stereotype. Oh, there's always this difficult case, you know. Oh, yeah. So that's what you need to deal with. How do you do that when Hank also was working at the Rasmussen, say, as a pediatrician? How am I going to do that as a simple doctor in one of our major hospitals? And he came up with this system. And it went over time. So we said, well, wait a minute. What we're going to do is we're going to get a set, we're going to first look at this strategic thing. So we need to have an idea on how we get this under control. We need to measure that. Right? We need to get these diabetes 1 kids and their parents, and we need to measure that. But that's not the first thing. The first thing was we need a program once we have found that these people have diabetes 1 of 4 weeks where we're going to train the kid and the mother and the father and the grandfathers and whatever in a 4-week program, because we need to do that. They need to get control of their life. And then we need software that will be able to, see how things going, give us a call, we looked at your system, and if that is, we want to react and we want to act upon it, or if you have questions, we need to do that remotely, otherwise there's no way. And we need to make sure that if people know what we're wanting to do this, that their peers, somehow we're going to help them deal with this and say, this was, I know you're 16 and you want to drink too much beer, but it's probably not the best thing. So you need to arrange with that, but you also need to set everything. That's one thing. But the other thing is they became so successful in doing this that the Erasmus was flooded with diabetes 1 patients. And wait a minute, we cannot deal with that within the university system of healthcare because we're not used to that. So that's why they put it outside. Let's have, it was called in Portuguese terms, an integrated practice unit. We need to have patient certification. We need the outcomes of this patient certification. We need to understand the different, not only certification medically, but specifically certification socially. We need to understand what the social situation of it, not because we want to sort of correct our numbers, we don't care. We know that we need a different intervention with these patient groups, so we need to be able to sub-stratify in doing that. And we need to organize in such a way that our unit can deal with 5,000 diabetes 1 patients, either in diagnosis, in training, and in monitoring. So they created, I always call it sort of the Starbucks model. They figured out how to do this. It's much more complex than Starbucks, to be honest. But to figure that one out and to make it copyable. To have it 5 in the other way. And so they have 5 or 6. And I must say that Medtronic is, I believe, the prime shareholder of it. But of course there's a lot of regulations that they cannot influence, not even sell their products in any other way than they normally should. So there is some regulation and some strict regulation actually on that. Still, it's very useful. It goes too far to describe the Medtronic case in this, but I need to. So that's what they did. So they organized it in an IPU, and I think we put it in the package, and otherwise I'll make sure we send it to you where it's well described on how it works. So they've done the Porter thing. They have the outcomes, they have certifications, they have the cost per patient cycle, they have the electronics, they have the internet stuff, but not in one day. They started small, figuring this out, say, yes, we have this big problem, we have this big idea. Number one outcome is we want to make sure that the mortality rates go down, that the quality of life goes up, and the psychology is better. And they were not perfect, these measures, but we need those. We're going to start with what we have, we're going to measure those. And we have a theory, or an hypothesis, and I admit a working hypothesis, on if we do this and this and this, it's probably going to work. So they started learning, not doing it in perfection. And that's how they continue to build this system. But over time we do this, and actually the interesting thing is that, for the people here, is that at some point they have now 10-year contracts with the health insurers. 10 years. Wow. You think, what are the health insurers going to do then in these 10 years, right? Because they have now a contract and, get rid of those people. What do you need to do? But the interesting thing is why? Because, of course, why is this value? Number one, you can measure it on the patient level, correct? You can see it on the patient and the family level. There's no doubt about it. And if you don't do it, it's clear. The second thing is, you are making sure that the health insurer, from his P&L, sees that a lot of the costs that he didn't see because all of these children going to the emergency room are lowering. And I told them you should have in your contract a kickback fee from the fact that you're reducing that number. I think they forgot a little bit about that in their contract. But okay, they're happy anyway. So, but that's a real value. The third value is, what do you think on a societal level? Children, schools, parents, working, enjoying life. Wow. The message of that, not fully, but and I like to stress that value-based healthcare has the assumption, I think the right assumption, the value is created at the micro level. So if you cannot explain directly what the value is for the patient and the patient group, I don't know what you're talking about. Because there is no relationship between the average of a quality-adjusted life here, and I've done the calculations, and I understand that you need them for some hospital, for some healthcare decisions. I'm not saying it's wrong, but if you do that and you think it has any meaning for a doctor and a patient, it doesn't. Don't ask politicians to say, what are we willing to spend per year on, what's the worth of a life, of a year for a person in this country? It's an immoral and ridiculous question. What do you expect? Doctors to have a calculator? Say, oh, well, if we do this, it's going to be 3 years, so it's going to be 50,000. I don't know why 50,000, but in old health economics stuff, it's 50,000. So it's 150,000, we're going to calculate this. And then you have some in industry, maybe, who say, oh, value. Okay, well, apparently you said it's 50,000. Well, if we put our stuff in with yours, then the value is 5 years times 50,000 is 250,000. You want to pay for value? Here's the price. It's ridiculous. And I know I'm oversimplifying, and I know there are people with higher ethics in this room, but it's a problem we created by not being, and I think, I wish I was so smart, this poor Elizabeth to figure it. I didn't. Because if you have this, how the hell you get it done? They got a 10-year contract, and in the contract it stipulates outcomes, and ambition to improve outcomes. It stipulates stratification, and it stipulates a commitment to a lower cost per patient cycle. Not a lower cost on a budget level, per patient cycle. That's a real difference. And they're willing to do a 10-year contract. Why? Because you don't need to be extremely smart to understand if you got this addressed, your costs are going to go way down. Even from a health insurance perspective. I'm not going to say every case is so beautiful as this one, but you need to be practical. If there are questions on it, we can have it over dinner. There's more to say about it. I'll see if I can send you. Okay. Questions at this point? Clear? They just follow the. If you look at it, I'm going to send you because you're just going to see the 7-8 points we teach in the green belt, and you saw Porter saying it's only a lot of work to get it going, but it's done. Use it. If they have software to do this for this, you probably can use it for something else. Talk with them. They love to have you over. Really do. Okay, Glad, Denmark. And we checked that it's not, and you may do that. Glad has the problem. So Glad was the winner last year of the William Bestelke Prize. I'm elected to the William Bestelke Prize. And I'm really happy that they won, but I'm not the voting chair on this. So don't criticize or blame me on that. It's the jury. It's not me. You know. So they were really happy, and it's in the name as well. So that's the website of the winner, and the next one is Elizabeth Thijsberg, who together with Porter wrote the book. So she was sort of. So this is Glad. What's the issue? The issue is osteoporosis. So it's apparently a big issue in Denmark. Well, not only in Denmark. And the big issue is, of course, your osteoporosis, and then, you know, you're going to get a new knee, hip, or whatever you need. Now, that's fine. But they knew from literature and from research for 10 years at the university, most of it is avoidable. You can prevent this. And even if people are really having difficulty walking osteoporosis, even if you give them a trainings program, which is not rocket science, if you start them moving and do things, that even if they may need a knee or hip replacement in the future, or nearby, they'll be much fitter, the outcomes will be much better. So the key thing to do is, and I can see this sort of academic, frustrated people, and I know many of them, we know how to do this. And I told them, and I wrote the papers, and why are they not doing it? Well, because you don't have a clue about implementation. I mean, being right doesn't mean anything. Getting it done is the key trick. So they figured that one out, and that's why they won it. So they said, well, wait a minute, if we do this, we're going to write this program, and we're going to talk with these physicians, and we're going to measure the outcomes, we're going to test the programs, we're going to do that in Denmark, but we want to get the outcome data and the stratifications and the process back. So we can write papers about it, no doubt, but also because we do it. And we put labels on, and we show it's better, and we have better practices. Plus, we can show quite easily that it will mean two things. And this is what I personally like the most. One is, of course, you can avoid some knees and hips to be replaced, which is great for those people if that's for them good. But it changed, hopefully, the discussion what I see in my country, where there seems to be a big pressure on having I'm saying this with you're not taping this, right? Don't quote me on this. But there seems to be a pressure and some early evidence of trying to reduce the usage of knees and hips as much as possible in people. And if they do, let's take the lesser quote. So there are some people who say, if you're 70 and you need a new hip, nah, maybe the wooden one, or I don't know. And then if you're a doctor and you say, but this is not a typical 70 of what we in average on consensus thought, and then they need to write like madmen, they need to be almost novel writers to explain that they want an exception for this patient to have another knee or a hip. Because they're very fit and they can run a marathon, for instance. That's the wrong way. So I hope that they will show, they promise me to show it, that number one is we get rid of these ridiculous general rules and look at the patient. And say, let's get the patient in osteoporosis better. And then if they need a hip, what's the best hip for them? And we can, if it's a budget issue, and ultimately some things are a budget issue, if we can do this in a smart way, then of course we will be able to pay for the 85-year-old who may benefit 2 years from the golden hip. Don't worry about that. You know, the biggest cost is not a hip. Come on. Give them a good life. They pay taxes for I don't know how many years. Don't scrutinize them for doing that. But the key thing is not that. The key thing is socially, right? If you start training this osteoporosis, why do people not move enough? They don't move enough because, I don't know, they get frustrated, or they don't like to move, or they're lonely, or they don't go out of the house, or it's cold in Denmark, I don't know. But by training, you do that together. And of course you need to talk about the diet, because the weight has an effect on, although I understood that more weight may be better, but I really didn't get that. But you can think about the diet, so you suddenly create something else in a better way. Is this perfect? Of course not. If you go to Denmark, everybody, no, but you can see the progress, and you see it in the fun, you see it in the numbers, and these people. The fabulous thing why they really want it is because they brought this system to the rest of the world. They try to expand this to other teams in China, Australia, Canada, Switzerland. Why? Because that's the key trick of the future. Why do I want to have the data of all the Portuguese patients? Is that interesting? Maybe a little. Your country and my country is way too small. If I want something personalized, I need patients like me. It's very likely they come from Portugal or Denmark or the US, not because they happen to be in the Netherlands. I want that. So it actually makes a lot of sense for them to do this, and it seems to be working. So not only have they shown how you can go from academic to practice, how you can get a better payment, and how you can create data internationally in doing this. That's why they want. For a very difficult issue, right? Because if the only question is knee or hip transplantation, yes or no, we have the wrong team. The team should not only consist of that final question. That's ridiculous. And then just do, let's say, prevention 1, because it's already a problem. I hope, I don't think they're going to do it, but I hope they're going to move it a little bit further along in terms of prevention, because that's the issue that it is. But at least it shows an intervention. And the interesting thing is to say, well, we now have a mechanism and we're going to expand it to backpack. And they told me they want to win the prize again. I said, really? Yes? With me? Funny, isn't it? But if you look through it, they create an integrated practice unit in different countries in a network. Wow. Is it perfect? No. Are they still frustrated? Yes. But that's what they do. And they just did it. And I was surprised they won, to be honest. So let's go to Germany. Germany. In Germany, very well-known case. If you've been to Harvard, and a lot of you, or a couple of you have been there, it's sort of the simple, straightforward case. It was done before Porter wrote a book. Right? So, and that's good, because I think it shows this is an evolutionary process. This is not intended to be, oh, now we have a new thing, per se. There's a real problem. We think this is the best way to do it, but it's not based because we were only, let's see if there are some examples where it already works. And we don't know, when they were doing this, no clue on how to do this in oncology. No clue how to do this in internal medicine. No clue how to do this in primary care. Really. Now we know. 10 years of struggling, figuring it out with a lot of fun. Now this is, most people know it, let me just, the prostate cancer case. There's still some work for me to do here. So read the case. I'll ask the people that raised their hands what they thought of the case. And if you want to let me know. It's a core case. Let me try to do this simple. Let me say how I normally teach this case. I tell them, you're a doctor, right? I hope you can see it. The Martini Clinic in Germany posts these numbers on their website. So they tell the world, if you have prostate cancer, you're diagnosed with this PSA test, or you have another reason to think that you may have it, well, we have some news for you. It's love or life, huh? That's the disease originally, love or life. So if you have this thing and you need an operation, surgery, then if you go to anybody in Germany, you will have full continency in 56% of the cases, with us 93%. If you go to the average, around the corner, severe erectile dysfunction after a year, 75%. Wow. With us, still too much, but 34%. But the key thing is, they put it on the website. Do you think the rest of the prostate cancer urologist people love this? Yeah, they applauded them. They said, great. No, of course not. They did all the things you can think of. Oh, this is not true. We don't have epidemiological data. They're selective. Yes, of course, they're only cherry picking the patients. Blah, 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 blah. And I said, even if they do, where are your numbers? And also in my country, when we showed this, people people got mad at me. I don't know why they got mad at me. Sometimes I know, but I didn't know this. Yeah, but we're also very good. I say, really? I think you are. But do you think your colleague in the other hospital is also very good? Yeah. We're better. Really? How does anybody know? The only thing we do here is having an average protocol. Don't take me on this. An average protocol that for patients gives a rule, and we decide for their love or life discussion. There is this idea that given the pathology, and there's good literature on it. I'm not going to say it's lousy work, it's very good work. And we need that research. But if you, and here's the trick, if you are able to get less erectile dysfunction problems and less urinary functions, then you may want to operate people because you're better. And the average thing would say, don't do it, because on average we are all equally good or bad. And that's what you don't want in healthcare, because it's no fun, because we don't want doctors to just follow protocols or sort of have their own ideas on how to do things differently. We want to improve, because we need to create this cycle. Now we know in prostate cancer, I'm not going to quiz you on this, so I'm going to do the same thing as like, what's the medical strategic problem with prostate cancer? The medical strategic problem with prostate cancer is not per se diagnosing it, a little bit, but the key issue is, once the tumor is there, what's the pathology of the tumor? So, you're going to die of something else, unless you're going to be 120, it's probably not going to happen. It feels a little strange, but we're not going to do it. Or at least we're going to discuss with you if there may be reasons, but you're really going to go, bananas if you think you have a cancer in your body and you know where it is. But the pathology is number one. And then where it is, how much nerve sparing, or where does it sit? And that's a sort of a love of life thing. That's the key thing. So if you want to improve with all the things you want to measure, the quality of life and all the things, please measure them. Nothing against it. But the core is the pathology and the ability to operate and to have the right practices in terms of, do we first do chemo, or do we do hormones, or do we do surgery? Those are, let's say, the simple 3 key items in all the things you do. And that's what you should focus on. You should do all the other things well. You're right, there's lots of complexities in operating prostates and the pathology of cancer. I mean, it's really fascinating if you don't have it. but I can understand why people want to dedicate their lives to it. It's fascinating. And there's a lot of complexity because people want to do a good job. And they do. But if you look at it from a value-based healthcare perspective, you say, well, wait a minute. This is driving the biggest part of the outcome. So we should heavily invest in getting the pathologies right. Getting the surgery better and better until we go bananas. Getting a very decent, as much evidence-based as we can, meeting on, we have this patient with this pathology, with this social structure, with these psychological issues, or not, with this, where it fits, and we need to think with our chemo people and the other people, what would be the best treatment, what we think, and now is the real thing. Are you ready to say, we expect this? Don't kill us over it, but we do this because we expect these outcomes, but we understand that we don't want any payer or any government agency to second guess you on that prediction. Say, oh, but you said it was going to be, say, no. Wait a minute. We're not magicians, but we think that this is what we should aim for, and this is our theory. If we do this and this, if we have this operator, and if we do this, then we expect on these 4 or 5 things that this would be the results. Are they? They may not. Because what's the thing in cancer, in oncology, it's a little less with prostate than with all the others, is even though there is a treatment plan, the treatment plan is hardly ever fully fulfilled. And there's a real danger with that. if you don't look at the outcomes. Because you start to assume, because the group here thinks, oh, this looks like this and this and this and this, and we do this good, and we have all the data, we have it organized. And they assume mentally that the treatment plan is going to be followed. And that should result in these outcomes. But if they don't have the feedback loop, they're going to continue creating the same treatment plans. Although it's very hard with chemo and other things to see it work. And the real progress from a value-based healthcare perspective is that learning cycle. That's why the Martini Clinic case, I hope you're still with me, is an example. I do not just use it for value-based healthcare. I use it for an amazing case on learning. And I find it even more fascinating than the whole value-based healthcare. How did they, with a bunch of doctors in an academic setting, because I'm an academic, I know how that works, in an academic setting, how are they able to stay within the university system, to work with all the other people, but also have a little bit of their special unit? And of course they need to deal with who's going to pay for this, and who's going to get the PhDs, and who's going to get... And they still are able to maintain that in such a way with the benefits of university, the downside of universities, with the benefits of a dedicated clinic and the downsides of it. And what's of course the real genius, if you are in industry, I'm not talking per se about the Da Vinci robot, we can discuss the Da Vinci robot or pathology, or you have a new drug. Who do you need to work with in the world? The Martini Clinic. I mean, you want to do something new with some, drugs or chemo, or and you don't work with them? What are you going to say? Oh, well, they don't think it's a good idea. Why do you think I should think it's a good idea? Because they have the pathology of these patients. Now, the interesting thing is I did bring that graph. I don't want to do that, but I can do that. There's a lot to say about it. But they started with whole beginning. So there's quite a nice video, but we don't have the time for that, for Hartwig, who's run this. And he said, I'm a surgeon coming from the US, in Hamburg, become a professor in neurology, interested in prostate cancer. I didn't have outcomes. So I just started writing down the outcomes that I needed for my first 20 patients, because we had 20 patients. We had 30 patients, and I just learned these new techniques and these new ideas, but we had 30, and then it took him, I don't know exactly the years, but it took a lot of years before he brought the system in place. But he started not with outcomes. Important. He started with thinking about the patient and a good idea on how to address the fundamental issue. So my suggestion is, with value-based healthcare, don't focus on small things. There's so many big medical, social things that we need to address. Let's try to be brave and let's do that and know it's a journey. But the team is the thing. And yes, you need outcomes, of course, but they don't need to be perfect. You can work on outcomes over time. And it's great we have ITU, and we are great we have the NHS, and it's great what we see in Denmark, and they have great institutions in the world that have wonderful outcomes in terms of measures. Use them, but make it small, and the key thing is get your team. Now, I don't know how I'm doing in time. There's one sheet I want to show you for that, because there was a special request. I want your Portugal in this list. You should be. Find a big issue you have here, or you want to deal with, and let people work together and bring in the rest of the world to help you. Because most of the things have been sort of done somewhere else. But you have the issue that we have in my country. We are too small. It's hard to get enough patients. It sounds ridiculous, but we don't have enough oncology patients in my country compared to the people that want to do that, which is slightly an issue. Okay? So we need to do it. So but there are many things you can win here, and even if you start, we have a special category which is called the dragons. That's my thing. But what I want to show here is, this is the decision group approach, but I still, because there was a question, how do you do a project? There's lots of things to say about how to do a project, right? But let me say what we think is always important to do with your group. And I know I don't know in Denmark, but in Sweden, they start always with the patient immediately, what they think, and they have the doctors and the nurse and often the payer, somebody from the hospital, from the government or from the county, whatever, who's responsible, to sit around the table and do that in the Scandinavian way. I'm not a Scandinavian, so I can only say what I hear. But they have a tendency to first start to each other. I think they learn that in school, do this in groups. And that works, they say what works for the patient and they get it going. I don't know, I'm just an economist. In my country it works slightly different. You start with doctors. You start with doctors. Not with anybody else, the rest is shoving paper like me, not interesting. You start with doctors and then you talk with them. Say, what's your medical strategic idea? And are you brave enough to go do this? And I don't mind if you're not brave enough. But then we know, right? and that's not an issue because you're going to get a lot of pushback in the system. You're going to get a lot of pushback. You're messing with other people's departments, right? And you need to build that relationship. You want a different deal with the payer. There's somebody responsible for that. The data analyst is really not that eager to change the definition because they have their budgets and their ideas and their things. And people are going to look at you like, really? Why do you think you're so good? Right? And in academia, we have some information that says, well, prove us something before you do it. So I need to arrange, I'm talking about the Dutch, I'm not sure about Portugal. but my job has been, a lot of the times to say, oh, so you want us, not this doctor, you want us to prove the future. Great. So we can only do this if you know up front it's perfect. Really? So what you do now is perfect? You want to see the data on what's evidence-based in your decision making? You want my humble, non-doctor view on that? I think maybe 50% on the patient is evidence-based. And you'll say, well, Fred, not really. And then you have clinical staff. And I think it's important that we capture what you do, not that you figure it out and then keep it for yourself. That's where we can learn. You have an idea why this worked. That's what we need to learn from. And you should get an award for the worst outcome with the best idea ever. Because we want you to encourage it. That's entirely different. That's what we try to do. So don't stop changing a very good thing because you want it perfectly up front. And what you're doing is not perfect. But of course it's healthcare, so we need to be a little bit conservative. And we need the ethical committees, and you may need to do it double. We're not going to mess with that. But we don't want this nonsense of bringing perfection in a system that cannot be perfect. That's what we do here. But apart from those little thingies, I'm just saying you need to be a little brave. And in my country, it's a doctor. That's why I think we're quite successful in value-based healthcare because we have some say stupid, but courageous doctors. That's probably a little bit of the Dutch. Fine, we have a government. Well, if they're not in the way, we're just happy. I have the impression it's slightly different in this country. But at least we're not that obedient. I don't know why, but for whatever reason. So we just try it, but we understand that we need to collaborate. We're going to start, we're going to bring in everybody, but not to mess with this, and say, give us time. So you need the good people who are in position, socially, who are able to convince, like the diabetes people. Say, we've done this, we talked with the dean of the Erasmus University, we sort of did this, we make sure we have the committee in. We want to already bring some other people to give us advice, not to mess with us, to give us advice, and we're going to focus on the team. The team. What does the nurse think? What does the patient think? What are they going to do? What is the data kind of? What's the PhD going to do? Okay? So let me now finish because I think you're too polite for me because I love this so much I'm going to spend the whole day. This is what I suggest you always do. This is not official value-based healthcare approved. And I'm going to explain what it is a little bit and then what. What I suggest, if you want to do value-based healthcare, you don't need to do value-based healthcare. Fine with me. But what you need to do is be very clear on what the medical condition is you're going to talk about, including patient certification or risk certifications. You need to be damn sure where does it start, where does it end, what's in and what's out. Because otherwise we go bananas. Don't use only the medical definitions. because they're very good. I will start with those, but you may need to something else. You say there's more social in it, there's more prevention. You need to be very clear and spend some time on thinking about that. You need to do something that you have clinical pathways, right? And these, how you deliver that. They're good. Don't start with them. Don't start with them. I can spend an hour on why. You need them, but don't start with them. Start with the activities that relate to the required outcomes. So I gave you the example of prostate cancer. In prostate cancer, you know, the key thing is getting the pathology and the treatment plan right, the discussion right, and the planning of the surgery right. Those are the three big things. If you look at the clinical pathway or at any of these other health pathways, you get confused about all the little steps. And these steps are basically on average. That doesn't mean they're very useful. I love protocols, you have great software these days that support it, but I've seen many projects where people did not do the intellectual work. And then you don't know what the effect is, because you're suddenly looking at a step, not an activity. This is not a Porter thing, this is Fred's. Okay? Stick on these patient-relevant medical outcomes. Patient-relevant, patient and family should understand it, and we as a team should be able to act upon it. Don't measure anything you cannot act upon. You may want to measure it because 2 or 3 years from now you have the ambition to do something with it, fine. But don't go measuring 600 things. I always have discussions on the 157 quality of life measures of the SQ I always forget. And I say, if you want to measure them for academic reasons, please do. I have no problem with that. But the question is, what are we going to do with that? If it's prostate cancer, it's depression. Let's measure that then. Right? And not only of the most of the time the man, but also of the partner. So measure that, because that's relevant and you can act upon it, not just with pills, but also with pills. You know you can do something with it. Or you say, I need to measure this, and the nurse needs to refer it to somebody else, and we want to know who we refer it to. But don't go into the mechanics, and you just need 5 or 6 or 7. Then these patient initial conditions, these case mix variables, they are important, but they're not so important to correct your outcome measures. That's fine with me. And I know that the biostatistician and neurons need to do it. I'm not against case mix variables, but the key thing in value-based healthcare is that describes your stratification, and your stratification description describes what you need to do. Because the great thing of a case mix variable is, I don't know, age may matter, or smoking may matter, because you know there's a significant effect on it. Great, then up front, we have somebody who smokes or who is old, or whatever. That probably means this pathway, probably. And we want to think about how can we improve that, because we're doing an amazing job on very sick patients. And if you're not careful, and you haven't stratified, you're only correcting in the back. You need to stratify in front. If you correct only in the back, you may get people who are selecting healthy patients, because I'm not going to do this patient because it may ruin my outcome, and I need to discuss that. And that's absolutely, you should be very, you need to be very, that's absolutely not the thing. If there's kidney failure and I need cardiology, and somebody's too scared to do it because this patient will ruin my statistics, I need to do it. And now I'm going to stop. Oh.
Yeah, but that's the wrong aspect of clinical stratification, risk stratification.
Absolutely.
You have the good part, which is being able to benchmark and to compare with the other outcomes.
Correct. So you need.
We had a surgeon in the country that is very good,
yes,
but was known to take low risk.
Yes.
While other hospitals in the region or in the country are known to take high risk. So when for individual outcomes it's perfect, when it is up to compare or benchmark outcomes, you need to address the complexity issue.
You can compare it to it, and I think we totally concur, but just to, and then I promise I'll stop, is you want to compare, but you want to compare apples with apples. And the moment you compare the outcomes, you can compare and say, well, we have these outcomes, but now we're going to use, let's say, the case mix variables to correct them. That's one way of comparing.
Yeah, case mix for population.
Correct. So it's within the 95% thing, right? That's this. Nothing wrong with that. Nothing wrong with that if you look at the population. Now we're looking at, we have the issue of an individual patient, and we have, let's say, a group of patients, and we should call it stratification. What you want is you want to compare your surgeon's team, not only the surgeon, please, but the surgeon team with, let's say, the same sort of starting, the health start point, and then see what the output is, and then compare this with maybe another team that does the same thing. Or the other team has more stratifications.
For that, you need a lot of numbers. You need volume. That's why.
Oh, you need volume.
That's why marketing clinic is so good, because it does thousands. Because then it dilutes, the case mix flattens. If you have a lot of patients.
So in value-based healthcare, we typically do not use this. We use it for reporting other reasons. You try to use this. Now the question, and then I'm going to end, because now I don't have the answer to it, but yes, the Martini Clinic is great because they have now these patients and they can do these certifications. So it's not that they need a lot of data per patient, right? They don't need a lot of data, they just need a lot of patients. That's perfect. But they started also with the 200, the 20, the 400, the 300. It's not statistically relevant. You only see a variation. You don't know if there is a relationship from the numbers. But then comes the team. And then my suggestion is, what could explain the difference? Not that you're better, but let's just have a look. Let's just see. And the good thing about this from a change perspective is, almost all the time you see a team that does a couple of things very good and a couple of other things scores lower. Not because it's statistically significant or whatever. They just seem to have a lower score. That's an opportunity for learning. Of course, you need to look at the numbers and sort of well done. But I've seen in cardiology in my country, when they started, now they have 10,000 patients in it. They also started with 200 patients.
But that's the secret of marketing clinic.
Absolutely.
They flatten variation.
Yeah, but not when they started.
No.
So that's the secret in the numbers, so we compare. But the interesting thing about the Martini Clinic, even when they didn't have the data properly, they started learning.
Yeah, sure.
They said, what could it be? Let me see how you do this. Or we think about this. Or there may be an issue. Or let's look at the literature, what may explain it. We don't know if it's the case. Let's see if we can find some evidence if this would work. You got me talking on my favorite topic. You also I didn't have the slides, so I, not only as a professor, I like to discuss that. But you can get me for 3 days on this, but I think it's probably wise to end this. I hope that
That's a good question.
you may ask me any question you like, but just make sure on your time.
Yeah,
for the group, not for me. I'm here all night.
Just a very brief question.
Yes.
When Michael Porter decided the complete cycle of treatment,
Yes.
of course, we're following patients for 5 years or 10.
Yes.
Now, that TDAB,
Yeah, the activity system.
which is time-driven activity-based costing,
Yeah.
that in fact relates to what happened in the hospital, right?
Correct. In his example, but not per se.
But then you're losing all the rest. I mean, I'm not criticizing.
No, I understand.
I'm saying that's the only way we can do it, because it makes part of the simplification. Because the majority of costs are in hospital costs. The other costs will be if you get into complications.
Let me give from a practical note, I don't know about your country, but it probably is. Conceptually, it doesn't matter if these activities are in a hospital, are in other hospitals, or in a whole chain. We've done this for for some primary care things in trying to do this. There's a lot we can say about it. So conceptually, there's no limitation. In practice, and that's why the early examples were all in hospitals, because that was at least doable. At least doable. But we see now more and more a development in trying to do this in the combination of tertiary, secondary, and primary care, and try to do the change. But it's a lot of work, and I wouldn't start with it. I would start with the team. Hopefully, you got a little bit of this. And number one is there are examples. And more than examples. So I don't feel I need to say it can be done. The how is every time a challenge, and how do you get it done? But first you need to really understand it, and then how you get it going. I love that work. If you have any more questions or any other things, just feel free to link or reach out. We gave you a package of things we hope that are inspiring. And the fun thing of it is, you can figure it out for yourself. What is in your situation, your country, your passion, what's the good thing to do? And think on the big things and do it small with the team. And if you have the team and you have this package, and that's why I want people to do this package. If you have up front in 100 days, not you work on it 100 days, but you can quite quickly do this. You have this whole package, you can work for years on this. If you don't have one of these, and I've seen it in practice that people go too quickly to the clinical pathways or to go too quickly to lean techniques. I love lean techniques, nothing wrong with them. But then they get stuck after 6 months because A is no fun and B you need to go back to this definition and everybody's lost their energy. So this is more a transition group project. We want to have this first before we go too much to other things, and we want to make sure that the intrinsic passion of people in healthcare, the intrinsic motivation, why they want to be nurse or doctor or pharmacist, that you bring that out. And in my country, because like your country, we had a lot of these top-down cost pressures, and a lot of people got really, really sad, and that's the friendly word of this. And it needed to be done and not to be done, that's another discussion. This helped lead doctors in saying, we understand, we're not stupid, we need to deal with this. But what's going to happen after? Because we cannot continue on unit cost reduction. There's just no way that we can do it. But we can also not say, we're doing great quality things, give us more money. So this may be fascinating for our teams and get us through the storm. And at the end say, but these are outcomes, and we're lowering the cost per patient, like diabetes, or like osteoporosis, or like heart watch, or like people with COPD, and we have those examples. I hope you go further on this journey, and please feel free to use whatever we've learned, and that's why we founded Values Health Percent Europe for 2 reasons. Europe is different, meaningfully different, not with everything, so that's number one, and we want to talk about the implementation. Because the implementation will learn. And so far I have not seen yet, so I'm very biased, I've never seen a better idea on how to get your healthcare system sustainable and let people have some fun in doing the work. If you have any better thing, please send it to me, because then I'll just go back to my economics. Thank you. Thank you.
Without any further delay, since we are a bit late,
you could stop me anytime, I should have said that.
Marques Gomes, she's well known, he's Mr. Vivier in Portugal, so
Okay, first, thank you so much for the invitation. And actually, let me say that, thank you so much for bringing this great speaker today. Because for those of us who have gone abroad to discuss value-based healthcare, in international conferences, or went to Harvard or to the Dell Medical School with Elizabeth Eisberg, or worked at ICHOM, or even had your course as I'm taking it. So I've done the first session in 4, and so I can recommend the course. Of course, you can have the course and you can learn value-based healthcare at Nova University Lisbon, so please forgive me for that. And some of the cases that we saw today, so the Martini Clinic case, the Medtronic case, we learned that at Harvard, and we learned that also at Nova. But it's so great to have you here, to have your enthusiasm, and to be able, to share what all of us that used to go abroad, get from all these inspiring people that work on value-based healthcare every day. So I'll have 20 minutes, and in 20 minutes, I'll try to give my talk. I was asked to give a national perspective, so I will give what is my perspective of what we have in Portugal in terms of value-based healthcare. By the way, last year, at one of the meetings we organized, we had Professor Hartley Hulen, here talking about value-based healthcare, and it was really, really funny, because as a doctor, he said, and I quote, he said, doctors don't know their health outcomes. And you know, in the room, there was like 500 people in the room, like, oh my God, what is he saying? And so it's so great to have people like you. I mean it, because it's the real world, you know, the real world out there happening, and sometimes in Portugal, we have this difficulty, I must say that, to understand what is going on and to embrace change. This is how it is. So Portugal, I would say, is taking its first steps. There's a lot of interest here. Here, one of the conferences we organized in 2017, we call it Conference ICHOM in Portugal. We had 500 people here. With Christina Ackerman, we have everyone here, you know, Tom Kelly, everyone. Then, 1 year later, we organized the so-called Portugal Valley Meeting for Health and Care. And here, again, we had 500 people. So, no, in 2 years, we had 1,000 people at Nova University discussing value-based healthcare. And actually, this is what we, as a university, organized, but there are a number of conferences about it. Well, this is the 4th edition, a picture of the 4th edition. João is here. João is one of the organizers. So he organized the 4th edition of the conference Investing in Health, Financing Years of Life. But also the Portuguese Association of Hospital Managers organized every year several conferences on value-based healthcare. I think they have organized 8 or 9. So they just, you know, go all across the country and try to evangelize. Also, the Portuguese Association of Pharmaceutical Companies have organized last year a congress with ICHOM. So, you know, people are interested. And, you know, in Portugal, you have the private providers saying, hey, we're doing value-based healthcare. We do health outcomes measurement. We send our data to international benchmarking programs such as GLOBE or ALCAN, which, by the way, I've just terminated. Some say we do TDABC. The public sector also says that. So you have IPO Porto, for instance, the hospital of Professor Fragata, also, you know, and you have a number of companies doing value-based contracting. So basically medical devices company, pharma companies, and also insurance companies. So they're claiming in doing this, right? But let's go back, you know, and into an easy way. Because sometimes, you know, people read the article from the Harvard Business Review by Michael Porter and Thomas Lee and say, hey, value-based healthcare is like 6 things we have to do all together. So no way we're going to do that. Right? So let's try to deconstruct this. As we were saying earlier, you know, it's across time, all over time. So what is value-based healthcare? So value-based healthcare, look, is to provide healthcare based on value. Right? And so you do value-based healthcare when you have 2+ available alternatives, and you choose the alternative that yields more value. It seems really basic, but is it as basic as this? And the goal is to improve value. This is the challenge. So what we need to do is to, for a given cost, to improve outcomes, for given outcomes, to decrease cost, or both. Right? So then people say, hey, but it's difficult. Because you need, you know, the ICHOM standard sets. I say, wrong. And I say, for instance, well, look only at the mortality rate, if it's the mortality rate that you have. And if it's a mortality rate you can act on. And this is from Porter. This is the Texas children case. So you learned that at Harvard. And so you have, you know, at Texas children in the early 90s, before they started their value-based healthcare program, they started measuring the mortality rate for this Norwood procedure, which is really something difficult to do. And they realized that for these 40 academic medical centers, they had an average of 43%, but at the largest pediatric hospital in the US, which is Texas Children in Houston, they had 100% mortality rate. This means that every child who went into that OR came out dead. And actually, I met Kathy Cadbury. You know her. She was the head of value-based healthcare at Texas Children, and now she's working with Elizabeth Theisberg at Dell Medical School. And she told me this was incredible because after they started the program, value-based healthcare program, the first child to survive didn't have a bed. Because the nurses said, well, you know, it's an Norwood. The child's going to die. It won't need a bed. And value-based healthcare is to look at this and then transform that into this. So they organize healthcare, they organize the way that they approach the problem of the Norwood and so on and so on. But basically they started here with 100% mortality rate, and they came to 2014 with a little bit more than 12%. So ladies and gentlemen, this is value-based healthcare. This is a great example of improving value. So you don't need more than that. So the 4 foundational principles of value-based healthcare, as actually Bob Kaplan likes to say, are first, you need to measure outcomes. Second, you need to measure cost for every patient. Well, second, not necessarily in that order. Okay. Organize healthcare into these so-called IPUs. IPUs, by the way, come from those are from management, come from the idea of the SBUs, strategic business units, strategy, order again, and so we have this integrated practice unit, and make compensation dependent on value. Of course, in Harvard they say bundle payments, but it doesn't have to be. So, food for thoughts. In Portugal, now that we know what value-based healthcare is, who is really doing value-based healthcare? How many providers use their health outcomes, the health outcomes they collect, they learn from those data. They adjust their practices and actually improve value. How many? How many providers go through continuous cycles of learning and improvement? How many providers have reorganized their healthcare? How many providers know the cost of the full cycle of care for a patient with a particular medical condition? And how many value-based contracts have been signed with this? Well, I would say, for all these questions, a few, very few. That happens, it's happening, but it's a few. So, it's not pre-history, because it exists, but we start in history. Mankind has arrived, but still we have a long way to do. Does Portugal have what it takes? I think it's a very fair question. Do we have what it takes? Well, this is a paper that we're writing, so sometimes university can give some good insights. So we had basically more than 20 semi-structures. This is one part of the paper, actually, and we have identified critical dimensions for implementation in healthcare providers. And so we went to talk to a number of top experts in the world and from different countries. So here, for instance, in the US, we talked with Kathy. Here in Australia, we talked with Debbie Cole, who won the prize last year. Okay, and we found the following. There are 4 dimensions. First, leadership. Second, organizational culture. Current knowledge and data collection system. As leadership, we say a person who is knowledgeable in value-based healthcare, which is not always the case. Right? Has the so-called leadership skills, holds a relevant position within the healthcare provider. For the organization, I'm going faster, so for the organizational culture, do the people work on their common goals, they speak a common language, do they ask for feedback and adapt accordingly? So what is, the organizational culture of the provider? What do you know already? What outcomes are being collected? What does healthcare provider know about the patient pathways? What do you know? And also that data collection system. When to register the data. I say when, not where. Because you can start and do marvelous work just using pen and paper. Actually, Professor Ullem started with Excel, which is pen and paper. Right? Okay, of course, if you have IT capabilities that can go and integrate outcomes faster, because one key thing from this is it's important to present the results as fast as you can. Okay, so this is true, those are three critical dimensions seem to be true for healthcare providers, but this seems to be true also for the entire ecosystem. So what about our Portuguese NHS? Well, I'd say, and this may be shocking, but I'd say that the foundations are there. The foundations are there. Look, what we call in Portugal CRI, Integrated Responsibility Centers. Can those CRIs be what we call IPUs? Another question. These centers de referência, referral centers, as being defined as any service department or unit recognized as having the highest level of competence in providing healthcare. Does this mean that the Portuguese NHS will reorganize healthcare across the country based on the value provided by each healthcare organization? So the vision, the idea, the general idea seems to be there. In primary care, payment is often linked to performance already. Actually, when I go to give talks to primary care, they say to me, no problem. Just give me, what outcomes do you want? And we will work for that. We have data, a lot of data on clinical outcomes. And there is a culture of measuring performance. And we have data at the patient level. Actually, there are companies doing this for ages. Clinical outcomes, mortality rates, reparations, rates, things like that. But hey, you start with what you have. So what is missing? Of course, resources. Money is always an issue, and Portugal is an issue. Also, politicians are focused on volume because they're concerned with the long waiting times for given consultation or surgery. Because, let me say that way, 30 seconds more. Sometimes political parties ask me to go there and say things. And once, some really important guy from this really important political party said to me, oh yeah, I have no doubt this is like you're saying. But Mr. Sousa, and you don't know, but our president is called Marcelo Rebelo de Sousa, so I thought he's the president. So, but it was not. So Mr. Sousa doesn't know that. I said, who is Mr. Sousa? Well, Mr. Sousa is the guy who cuts my hair, who has cut my hair for the last 20 years. And he doesn't know that. And because he doesn't know that, I don't have a political problem. Right? And so, it's important to because for me it was really a lesson. Because part of my job will be to inform Mr. Sousa, right? Because after Mr. Sousa knows that, well, perhaps we will be able to progress. But what we have to say to politicians is whenever IPUs exist, we have faster treatment, better outcomes, lower costs, and also improved market share. We have demotivation healthcare professional, lack of autonomy of hospital managers, lack of knowledge about healthcare. And the right incentives are missing also. So how can Portugal move faster? Well, there are three approaches, to make this happen. And this is another thing we're doing with the French firm. We're trying to categorize countries and how they're doing things. So we have the top-down strategy, the bottom-up strategy, and in the middle, what we call encouragement for the Ministry of Health and strong bottom-up. And I like to see Portugal there. Actually, we have here a former Secretary of State who was in our conferences, and the former minister also. So, we have the Ministry of Health saying, make that happen, but you do it, basically. Would be good. And so, last May, Nova University, together with Health Cluster Portugal, we decided it would be a nice thing to organize what could be the Paris Agreement, not against climate change, but for value agenda in Portugal. And we went, to the stakeholders. Most of them are here. Those lovely meetings are great because we know each other right now. And say, hey, do you want to commit publicly in order, to move faster? And people said, yes, but if it's something too open, such as, value-based healthcare is important, we are not interested. We want a concrete goal. And the concrete goal is by 2021, 1/3 of our players should have had a value-based healthcare experience. So there's a lot of work to do. Bear in mind the incentives to move faster. Step up initiatives in the field, to stimulate the top-down approach. A top-down approach perhaps start by motivating healthcare professionals to organize healthcare into this CRE, so these IPUs. Also look at the costs. How much does it cost to treat a given condition in Portugal? In hospital A, in hospital B, in hospital C? Nobody knows. Which is incredible, because at the same time, everybody understands that the trend is to have higher costs in the future. Right? And also another possibility, this is for the Portuguese, this is just to provoke the debate, would be to measure the effect of the introduction of capitation or bundle payments in health outcomes, and we can start with the ULS, local health units, who are already receiving. Also, of course, everyone from the medical devices companies and pharma companies would say, well, yeah, it's important to have financial compensation. I agree with that. I can't agree more, right? So you can do that through value-based contracting, value-based procurement, these kind of things, but also competition is important. Competition per se. If you can have competition, is important. Look what is happening here with the private providers. Say, hey, I'm doing value-based healthcare. Hey, I have better results than my neighbor. Hey, come to me. I want more demand. This is competition. Right? Look also, for purposes of selling more in companies, the Medtronic case is a great case because they had to reinvent themselves, in fact, to being competitive again. Doing things completely different approach. They are providers, right? Part of them are providers, right? So, and also at the level of the healthcare professional, because medical doctors, I strongly believe that. I have medical doctors in my family. Good medical doctors, a good medical practice requires health outcomes measurements. They want to know. They want to know. So, and they want to know, and they want, they compete against themselves, so they want to have great results. So competition is key, but also, if this is not enough, the final client, the final beneficiary, which is all of us, should be the driver. Health outcomes must be publicly known as quickly as possible, so that Mr. Souza knows about the variation in health outcomes, and so that Mr. Souza say, hey, where am I going? What are the results? Likely results. Okay? And why people are saying, hey, you have to go to that hospital. I don't want to go to that hospital. They're killing people. And right now we don't know. Right? So it's important, it's key to have health outcomes and to make them, to do all this information very transparent. A question, where to start in my hospital, so it's pretty much the same thing actually that you said earlier, is to select a condition. I would say high volume condition, chronic condition or acute care, expensive, because you will have quick wins, and easy to work with, have clinical leadership, doctors here also, around that condition. Get the clinicians together and figure out what outcomes you want to measure. So you don't need, I go for this 5 to 7, this Santos case is a great case, for instance, the scorecard I have. Everyone should be measured. Encourage the clinicians to think about the right thing. So how they will reorganize healthcare around this IPU is going to be part of that IPU. Do the costing so you can understand your current cost, so everything, and you can improve it, and then you'll be able to negotiate a bundle price if this is what you want. And my experience, I don't have your 20 years or something experience,
12.
but 12.
12 on brothers.
All right. My experience, it takes 12 months to get some experience, to get some good results. So it takes some time. It's not immediate. But 12 months is not like that much time. It's some time. So also Nova, what are we doing, for helping Portugal to move faster? So in Portugal, we have now a semester course in value-based self-care, 28 hours at the Nova Medical School, and 36 hours at another school of business and economics. So this is for the master students, finance, economics, and management, and for the med students at the Nova Medical School. So you need them to, and then we have some research also, and we have some work in the field. This one is really interesting because it's an IPU, an inverse IPU. Basically, since we don't have an IPU, what if I had someone, just one person, that could bring, take the patient and go to every place it should. So, and we're going to see if that works or not. This is being done with João. This is a patient organization, Nova University of Lisbon, Prologica, they are here. Diogo is here, and also the Northern Lisbon University Hospital Center for colorectal cancer. Right? We have also HIV 360. This is basically a new standard set for HIV, and actually we're working here. We're leading this in Portugal, but we're working also with Martin Infar from Karolinska Institute. So we're doing this with Kim, with Zofia Dasgupta, former vice president of ICHON for standardization, and we have that great team and working on that.
We're going to give you some names.
Right. Also, we are just launching next month the itinerant conference on value-based self-care. So, when you organize those gatherings, which is great, well, we all know each other. So in the next conference, we all be there again. But there are a number of people that don't come to our conference, and those are the professionals that are in the hospitals. So we go to the hospital, and we give 3 hours of crash course as how can I start doing value-based self-care tomorrow? Okay. So we're doing this in the Portuguese public hospitals, and many partners will support us, and we are helping. It's incredible because I'm doing this in Brazil. I have some project there, and we are just starting here in Portugal this implementation of outcomes and transformation. But we're on the right way. This is, someone that changed our lives. It's called Walt Disney, and I will finish with this quote. He said, "The way to get started is to quit talking and begin doing." Thank you very much for listening. 20 minutes, right?
Thank you, João, pelo time. Well, como eu lhes disse no início, cão feliz é um cão saudável que tem comida. Como nós já estamos todos dados para a comida, o nosso amigo Diogo Reis decidiu a sua apresentação. Teremos ocasião de ter mais oportunidades, porque efetivamente
a apresentação na nossa página.
A apresentação ficará na página da associação. De modo, muito obrigado, Diogo, e as nossas desculpas, mas efetivamente podemos estragar a comida toda e depois colocam não somos felizes. Obrigado, então íamos descer para...
I have just a couple of comments. One, I wanted to always to mention this, and I was pleased to hear João Marques Gomes to refer to it, is that I am a believer that we do have good foundations in Portugal in relation to value-based healthcare, and maybe not exactly cases similar to the ones that were presented. I believe there are also some, but when we look from a more holistic perspective, I think what we have in our NHS, both when I look into what we do in relation to the assessment of the value of health technologies, this is one aspect, but also what has been implemented, and we have here Dr. Manuel Delgado, former Secretary of State of Health, recent former Secretary of State of Health, so he has been in the government until less than 2 years ago. So we have in our NHS a reasonable number of tools which are very, very relevant when it comes to contracting mechanisms, quality-based indicators for measuring performance, a high number of systems to collect information, to measure information. So these are, and João has highlighted this quite well in the presentation. So I think this is one point I wanted to highlight. So I think maybe we have started from this more broad approach, but I believe that we can, having these tools, we can bring them into a more integrated approach. So the idea of this IPUs or other ways of doing it. So this is what was one point. The other point I wanted to mention, and because I'm coming from the Medicines Agency, and maybe Christina will also touch on that because she's the one seeing the same issue from the other side. So she's coming to us to get the value recognized from our activity. But I think when we look into the assessment of technologies like medicines, I normally use more the British word than the American one, or others like medical devices. There are a number of aspects that we face, and maybe I just wanted to highlight. One is the evidence. This is still an issue. The evidence that we have available for addressing addressing value. Then the other aspect is many times to measure what will be the results, because we need to do that, and this is also something that we have to develop. I think we have done a number of things very positive. We have, for example, in the oncology field, and Christina comes also, and others here are involved in oncology. There are the other companies which work in oncology. In the oncology now we have quite a good system that I'm very confident on. The so-called RON, the National Oncology Register, which it will be a very good tool if we wish to measure mortality or survival rates or other kind of specific outcomes that are related to a specific drug. So these are aspects that we need to look at. There was another aspect that was not, for me it's always a little bit a mystery, or how we address this, is the cost, because we tend to like to go from the beginning of the chain until the end, but and we talk about the value, but for me it's still how we bring in the cost, because maybe in this case, if we are focused on measuring the outcomes of a specific approach, but when I'm asked to make a recommendation for a decision whether this new technology should be included or not in the available alternatives, then this for me is an issue, is a difficult issue. So I'm not able to address the value, either depending on what will be the outcome, if then I do not address the costs. So I think these were the points that I just wanted to briefly highlighted. As I said, I was pleased to learn about these very specific examples. They were very concrete and they were very positive. But this was just my little reflection that I wanted to share with you, and I thank you very much for this opportunity.
Thank you. Now we have the comments of Eva. As you know, Eva is the president of HOPE, that's the European Association, Health and Hospitals Association, and came from Denmark. and is a lover from Portugal and Lisbon. So welcome again.
Thank you very much. Hope is a wonderful name to be present for, right?
Hope, yeah.
But actually, I just want to be able to peel potatoes, or I just want to be able to walk my dog, or I just want to be able to do some gardening every day, or maybe I just want to be able to sleep at night. That doesn't help when I have to go to Portugal very early in the morning. But of course, these are statements from patients that had severe illnesses and who were admitted to hospitals where they were working with value-based healthcare. That's why we know it, because the staff asked them what's important to you. And that's exactly the point I want to make, because I agree with a lot of things that's been said, and dinner is closing in on us and so on. So the added value of asking the patients what's important for them cannot really be exaggerated, because it's so important. If we don't ask them, and we don't know. Often, probably clinicians have a tendency to think they know what's good for the patients, and then it ends up it's not exactly that's important for them. And in order for us to know that, also gives us a chance in actually to direct our resources in the direction that's important to them. So if it's important for somebody who had a shoulder surgery to be able to lift their grandchildren, then you can direct the training resources in that direction instead of something else you might have thought was more important to them, and so on and so forth. So if we keep thinking of that as an important aspect, that don't forget that the reason why doctors actually take the training is that they want to do something good for the patients, then you should also ask the patients what's important to them. So I think that's the most important issue I want to stress, and to take the more European view also on this. We all more or less share the welfare system and the systems where we have a solidarity principle of everybody's having the health care that they need and they don't have to pay for it and so on. That's why in these times also of crisis and so on, we need to keep it sustainable and affordable so we can still be able to offer the new treatments that are available. And that's why it's so important that the money we use in the healthcare system is used for the right purposes. And we can't really ask the patients enough, because I think actually that just there's a placebo effect probably in this too, that just by asking the patients also and using the data they give us, which is a very important aspect, then you actually make them aware also of what's important to them. And if we help them with exactly that problem, you might actually get them happier, and then they won't come see you so much as they would have, because they actually think this is not going too badly. I'm actually okay, now I can do what I wanted to do. And so there's a win-win situation if we're able to pull it off and actually show some real interest in the patient. So I think that's what I basically want to say. There will be some asking for cultural change as well. I don't know about the group thing in Denmark. We may be more used to doing things in groups.
I just gave you the Dutch view on this. So
but of course, doctors are very important anywhere, but groups are important too. And that's why it's been natural for us, at least, that the projects we've been having in this regard has been worked with a big team and also patients. And even then it's been difficult to have the right and the questions answered and so on. So it's really a work in progress and not an easy fix, but I encourage you to get on with it, because there's really some value in it, and I hope to hear more about it in the coming years, how far you've become, because I can see that there's big aspects of here, and you have big expectations maybe. So many people have been to conferences, I can see. So I think you are in a good situation to move ahead. So good luck with that. That's what I'm saying.
Thank you. And so finally, let's start the dinner.
We cannot use this in health, and I don't find out any answers for that. So I think we are in the right direction. But for many years, we and for many reasons, we delayed and resisted to use this approach in healthcare. I have no doubts as far as we can have no doubts. It is not easy, and we are, as was mentioned in the presentations, that we are in the first steps. And in Portugal, for sure, we are in the first steps. But I have also no doubts that this is the way. I don't know if it will take 1 century or 10 years or 20 years, but we have to go. And when we are considering, for instance, in Europe, as was also mentioned, with our welfare state, if we, this is my humble opinion, if we do not take care of the healthcare system, using approaches like this, or somehow taking care of the value, probably we will not have good news for the future, because the system probably will collapse. I don't want to be so dramatic and drastic, but I have, again, it's my humble opinion, but I have no doubts about this. I came from Health Cluster Portugal. Health Cluster Portugal, for those who don't know us, it is an association that brings together 180 something institutions from the Portuguese health value chain, and value-based healthcare is one of our bets. We are in somehow leading some pilot experiences, mainly on ophthalmology. We are in the first steps, but it involves 10 of the Portuguese hospitals, private and public hospital. It's difficult. It has been very difficult to implement, but again, this is the way. So, thank you very much, and let's do it. Let's do it, and let's see.
Bem, antes de mais, boa noite. Good night in English. Let's speak in English. So it's with a great pleasure that INFARMED has also the opportunity to make a few comments, not a lot, because for the time, I guess I learned also that in the Netherlands, whatever you talk when you are drinking, it's actually not the same. It doesn't have the same value, right? So no value for my words at all at the moment. So now, I guess it was a very, very interesting night debate. Thank you for the lectures from both of you. And I just wanted to reinforce on behalf of the pharmaceutical industry that for us, for the pharma industry, value is what we try to bring to the markets, to the patients, to the healthcare systems, to the society. So that's our mission. And so for us, it's very important that we can deliver this value. And delivering this value is not only to have the access to this innovation that we investigate, that we develop, but actually to have it accessible for all the patients that need it. And we have been facing in Portugal difficult times during the last 7 years, at least, since we had Troika here in Portugal. And at the moment we have one main issue that we need to solve before even we think about value-based healthcare. So I'm very happy to of course, to engage, and on behalf of Apipharma, the industry is very happy to engage in this new approach of value-based healthcare. But before that, I would like to emphasize that we definitely need to have the right budget also for healthcare. We are under budgeting healthcare in Portugal for many years, comparing to the rest of Europe, and this is the first and foremost priority we would like to reinforce. And of course, we also believe that value-based healthcare can be one of the solutions for the sustainability of the healthcare system. For us, it's very important that the system is sustainable, because we are not here for the short term, we are here for the long term. Our cycle of development and innovation is a long-term cycle, it's not a short-term cycle. So we are the main party most interested in the sustainability of the system. So I would like just to leave a final message that Apipharma and all the pharmaceutical companies are very interested to collaborate with all the stakeholders in healthcare, because we also have a lot of experience in value-based healthcare in many other countries. most of us, many of us also sitting here, many pharmaceutical companies represented here today, we work in multinational companies and we are already doing value-based healthcare in many countries. So we can leverage the experience from many of these countries, like we've seen in Denmark, in Germany, but also in Canada, in other regions, and we can bring this expertise and this experience and work together to find the solutions. So count on us and enjoy the rest of the day, the rest of the evening. And again, thank you for the invitation from APDH and congratulations for the initiative. It was really interesting.
Thank you very much. E para terminar os comentários, se calhar começamos com aquilo que é o princípio, os doentes. E portanto temos Elsa Mateus, representative of the patients, is the last, but of course we're going to talk about the first, that is the patient. Elsa.
I'm used to this. Well, thank you for inviting me for this such an important event. For us, it's such a great pleasure to be able to take part, an active part, when discussing value-based healthcare. And I would not take long, but I have some notes. One of the things about value-based healthcare is to have the patient in the center and involved, and actively involved. Having the patient is not having only the patient as subject of research or as a subject to respond to the patient-reported outcomes surveys. It means to have the patient representatives involved as a stakeholder, as a meaningful and active stakeholder, as a partner in the process. And when we are talking about partnerships, then we must discuss the process of co-creation. We can co-create and co-produce or co-design, whatever you want to call it, depending on the trend. And we need to train. It's our role in UPATI, the UPATI Portugal organization, which is UPATI is the acronym for European Patients Academy on Therapeutic Innovation. One of our roles is to educate and to train patient representatives to be able to take part in these processes as stakeholders, not just as subjects. And one of the words I've heard this evening about value-based healthcare was about teams. And if we're talking about teams, then you have to have patients and patient representatives on board as stakeholders. But for this, we need to provide training, of course. We need to discuss and involve them actively. I have also some notes about these things, these gaps, when we think about health outcomes, many times we think about physiology instead of thinking about psychology. Because for the patients, it's not just the illness of the disease is not just about physiology or biology, it's about psychology and how this impacts his way of being in the world, and also about anthropology and how he relates with the society, with the family, with the work, and so on. And these were my main notes. We also have to think about the full cycle, because the full cycle, we need to understand what the full cycle is, mainly when we are addressing chronic conditions, and especially if we want to take a look on comorbidities and multimorbidities in chronic conditions. So this will also provide some complexity to the problem. But for sure we need to have some more value, and we need to have outcomes that have meaning for the patients, and therefore we all have a lot to win with this new approach on health. So patients are very keen on taking part on the process, and patients organizations and UPATI will be at your service to help you in this process and to have a meaningful contribution in this. Thank you very much.
It's quite curious that they call me the attention that as we have here today, doctors are very important in this subject, and I agree, because if you are speaking of health, you have to have the professionals, doctors and nurses, special doctors. And this is probably one of the works that we have to do in Portugal, because doctors are not so aware. The awareness is very, and the reason is we just have 2 doctors in this meeting. So we have a lot of work to do. As we have just 2 doctors, and the doctor we have invited from Orange Med, from our Portuguese association, doesn't come, I will give a special occasion that he do some comments, 5 minutes. This is a surgeon, and this is actual director of surgery of our hospital.
So, of course, I won't be long. I think I won't take even 5 minutes, but as a doctor and as a surgeon, I think I would like to also to say some things. First of all, I think that the concept of value-based healthcare is something that is not actually very easy to understand at first. And the first thing I think is that this needs to be diffused and well explained even to the healthcare providers. I must say that as a surgeon, and when I listened to João doing his talk and speaking about the need to evaluate results and change our practice according to results, we all try to do that, and we try in our practice to change our results according to what we find, but in practice what happens is we change some things, but we change very little, and our vision is very narrow. For example, as an oncological surgeon, I'm worried about that my patients are going to survive 10 years, and this is for me a good result. But I'm not thinking, how are they going to live all those years? If they are living well, they can execute all their daily life activities. We actually don't have any clue about what they are doing, and we feel this is something that is needed. On the other hand, we are not also aware of the values involved in the cost of those patients, because if we try to evaluate how much money was spent since this patient was operated until the day that we can finally consider him cured, this is something that now it's very difficult to achieve. I don't think that we have now the actual means to know exactly what is the cost of this. So I think that if we are able to understand success of a therapy in the perspective of a patient and what is good for him, and at the same time that we can use the costs in a different way, trying to achieve a better result with the same costs, or trying to achieve a lower cost with the same result, this is something that we can use to improve the care of our patients. And another thing that I think is that we actually have a healthcare that can support this. We have no money in our public system, and we have to acknowledge that, but we also have to understand that have the industry as partners is something that we have to acknowledge as natural, and we have to have a transparent relationship with them. Exactly. And understand that this is needed for this to work. This is the only thing I wanted to say. Thank you.
Well, and we arrived to the last, let's say, to the end. So personally, I would say, like I have learned in England during my stage in St. Thomas Hospital in London. I confess that I have learned, but I'm always confessing this. I'm always learning, and I want to be always learning. I'm like someone that have said, they tell me, you are a teacher. How can I be teaching if I'm always learning? So I'm learning to learn the others, so this is a continuous. So all these things what we have in debate during this dinner, I think they are important. As we have here, in sometimes it seems like elementary, my dear Watson, let's say everybody is in agreement that we should try to have the best results with the lowest cost. Very normal to think and to achieve this. I go again that maybe as we have here, that we have to be very modest. we have to start with certain pathologies, narrow experience, and trying special. And I go back, special for me, the more difficult, for me as a doctor, maybe as the economist or financial saving, that it's probably more easy to evaluate the costs, to have an idea of costs. It's more difficult to analyze and to have ideas of the called outcomes. Let's say, what are the advantages to the patient as a whole, not just because he's not dying in the next week or he's not dying in next year, but the quality of life. I go back to the health and wellness. Broadly speaking, for medicine, is not quite easy. It's complex. It's complex to analyze and to have. But this when one thing is complex doesn't mean that we say no. That there's no way of trying to do that. So I think we have to look to this approach and to see what we can do and to have good evidence, like we have done in medicine. We have some things that we have good evidence, others we have weak evidence, and others we have no evidence at all. But that's the world of science, that's the world of medicine, and we'll always be like that. We will solve, for instance, I've told, there are certain dogmas in medicine that have changed after 100 years, and they have changed now, and sometimes change completely. Let's say, and when you look back, you say, it's crazy why they have said that the reason was that the things were working like that. I don't understand, but it was different times. So thank you very much for the speakers, thank you very much for discussants, thank you for the audience. I think with all the tribulations we have in the beginning, we finish well, and I think we all always have learned something, and I will going on, because I think, like João said, it's a time for action. So, thank you very much, and see you next time.